Welcome. It is Wednesday, September 25th, and we have Dr. Tom Baer here with us today from the OHSU Night Cancer Institute. He's going to be talking a little bit about living and managing advanced prostate cancer. I'm very fortunate to have known Dr. Baer for a number of years and just feel honored to have him here to be able to chat to folks and answer some questions. So I'm just going to go through a few things today, a couple of housekeeping items. Again, my name is Evan Denhart. I'm the Vice President of Development for Zero, the End of Prostate Cancer. And I just wanted to let everybody know that today's program will be recorded, so just so everybody's aware of that. And also a quick overview of what today's format will be. I'm going to say a few words. We'll then let Dr. Baer go through his presentation, which should last probably about 30 to 40 minutes and or thereabouts. And then we will have a Q&A session. If you have any questions as the webinar goes on, please feel free to submit those. We will hold all questions and address those at the end of the presentation. So as you have them, feel free to submit your questions, and we certainly hope that we will get to them at the end, time permitting. Also, when you leave the webinar at the end or at any point throughout, there will be a survey. We hope that you take a moment to fill out your survey regarding the webinar and give us some valuable feedback as to what your thoughts are regarding the session today. Of course, we wouldn't be able to do this without some of our great sponsors. We'd like to thank Oncogenics, Teva Oncology, Bayer, eAlexis, Millennium, Astellas, and Medivation, who are all involved in helping to put this on today, and we, of course, thank them. I'm going to give you a quick overview. Again, this is being kind of put on by Zero, the End of Prostate Cancer. We are one of the leading foundations in the U.S. regarding prostate cancer awareness, education, and research. Our mission is really to end prostate cancer, and working with people like Tom Baer, we hope that this will be something that is in the short term, not in the long term. We work very hard to educate people, support patients that are currently going through a diagnosis or have recently been through a diagnosis, and obviously men that are at risk. We try and educate them as to what are the important factors so that they can hopefully live a healthy, better life and not have to deal with prostate cancer till much, much later in their life. Without any further ado, I would like to introduce Dr. Thomas Baer. He is the Vice Chair of the Night Cancer Institute here at OHSU. Very well regarded, obviously, with research across the country here in the prostate cancer field. And I will let him give you a little bit of background and then let him launch into his presentation. So, Dr. Baer.
Thanks, Evan, for the nice introduction, and it's a real pleasure to be here with the audience and with Zero, which is, I think, a wonderful organization. What we wanted to spend some time with you on today is a discussion of advanced prostate cancer. And so often the discussion around prostate cancer is around screening, early detection, whether or not the disease is curable, and what the initial treatment might be. But for many men, the disease becomes more advanced, spreads outside of the prostate, and at that point becomes a disease that we need to manage, but we cannot cure. Thankfully, there's been an enormous amount of progress in this area and a number of new drugs and new treatments that help us keep the disease in check and enable men to live normal lives with advanced prostate cancer. So today, what I'd like to do is introduce you to the concepts around advanced prostate cancer and talk about some of the treatments that we have available for it. First slide, I'll turn to Evan to talk about the mission of Zero.
Yeah, as I mentioned, this is just a brief overview of our mission. Trying to, as we say, end prostate cancer. Our name is our mission. We have one of the largest men's health event series in the U.S., the Zero Prostate Cancer Challenge. And that's one of the ways that we allow people to take action, raise money, and really be part of the solution for ending prostate cancer So that's just a little bit about us, and we'll move on and a little bit about our featured presenter.
I will move on. I know a thing or two about prostate cancer. Let's just leave it at that. I'm not going to read my whole intro. So today what we wanted to talk about is what is advanced prostate cancer, chat a bit about how one might determine one's disease state, talk about the various medical treatment options, as well as radiation therapy, talk a bit about clinical trials, managing side effects, nutrition, and staying informed as one lives with advanced prostate cancer. So what is advanced prostate cancer? Well, the simplest way to put it is a cancer that has escaped from the prostate gland and is no longer curable with surgery or radiation. It can take a number of forms, including locally advanced cancer that's spread to the seminal vesicles, glands that are right by the prostate, or regional lymph nodes. It can spread to further locations, and occasionally it can present as a rising and detectable PSA following surgery or radiation without yet any evidence of disease on imaging studies. As I've already mentioned, for advanced disease, there is not a curative treatment available today. We certainly hope to change that, but there are many different treatment options that can control the disease, support quality of life as well as longevity, and enable men to live with their disease at a high level of quality. One of the things that we wanted to start with is that early on in the course of defining the disease state, men are likely to have some blood tests for PSA as well as testosterone, and typically imaging studies that look for evidence of spread. Most commonly, those would involve a bone scan to look for bone disease and a CAT scan to look for any spread to internal organs or lymph nodes. This next slide is very complicated, and I think it might be best left as a reference for you to look at greater leisure than we have here during the talk. It's designed to detail the various potential scenarios that men find themselves in as they live with various stages of prostate cancer. I think what I'd like to say about this slide is that what defines what we call disease states is both the extent and manifestations of cancer. So is the PSA rising? Is there something on scans? Is there something on an examination that suggests the cancer is beyond the prostate gland? And also prior treatment. So it makes obviously a very big difference whether a PSA is detectable before any treatments happened or after a prostatectomy or radiation where it indicates a recurrence. Similarly, hormonal therapy is a cornerstone of treatment for prostate cancer, and a recurrence after hormonal therapy implies that the disease is resistant to hormonal treatment, and that further defines one's disease state. So as you think about where you stand in the course of prostate cancer, the two things that are important to have a full understanding of is what are all the manifestations? Is the PSA detectable and rising? Is there anything on scans? And then what treatments have already been done? And between those two, one can really hone in on what the situation is for that particular patient. With that as background, wanted to talk a bit about treatments for advanced prostate cancer. The cornerstone of treatment for this disease is hormonal therapy. And some of the newest agents that we have are in the hormonal therapy category. So although this is a treatment that's been around for 70 years now and earned a Nobel Prize, the only Nobel Prize awarded for prostate cancer research when it was first discovered, manipulating male hormones remains an exciting area where we can continue to improve therapy. Hormone therapy can be used alone for advanced metastatic disease. It is often also used in conjunction with radiation and surgery for disease that is thought to be curable but has a high risk of recurrence. And we know that combining local therapies with hormonal therapy can improve the long-term outcome for men with prostate cancer. One of the original ways to deliver hormonal therapy is through an orchiectomy, or surgical removal of the testicles, the main source of testosterone in men. This can still be done today. It has the advantage of being a one-time procedure that's permanent, and it is lower cost than most of the drugs that we have. It is irreversible, and for those men who are interested in intermittent therapy, it may not be the best option. There are a variety of drugs that accomplish various things with the hormonal system. In the middle row there, the so-called luteinizing hormone treatments. These are the injections that men get every 1, 3, 4, or 6 months that essentially accomplish the same thing as surgical removal of the testicles, but it can be interrupted and cyclical therapy can be considered. On the top of the table, you see so-called anti-androgens, which are blockers of the hormone receptor, which can be added to the shots. And on the bottom, there's a new category of drugs called androgen signaling inhibitors, which are more potent than either of the previous agents, and which have recently been shown to extend survival when conventional hormonal therapy no longer works. So these are important new drugs now available for the treatment of advanced prostate cancer. In more detail, the LHRH agonists, there's a number of them. They are all basically therapeutically equivalent, so don't worry about whether you're getting Zoladex or Lupron or Eligard. They're basically the same thing. They're administered as shots. They can be given under the skin or intramuscularly. And the differences between the agents are largely cosmetic. They can cause a flare, so for the first couple of weeks of therapy, we typically add a pill, an anti-androgen, to block testosterone right away so that these agents can have some time to work. Testosterone with these agents tends to rise for about a week or 10 days before it falls and stays suppressed. There's one new agent in this category called Firmagon, which is an LHRH antagonist, and it works very similarly to the more commonly used agonists, but it does not have the flare. So it can be useful for patients who have an immediate need for hormonal therapy, patients who are in pain, whose cancer is obstructing their bladder, who have disease in the spinal cord and concern about neurologic consequences of cancer. Firmagon is dosed every month instead of every 3 or 4 months. So in the long term, it's a little bit less convenient, but it can be useful up front as a drug that acts more quickly. Anti-androgens, most commonly Casodex, are given typically along with the shots, most often in the first month of therapy, and sometimes are also added later on if the shots don't provide full cancer control. These initial hormonal agents are very effective. 80 to 90% of patients see a substantial response to these agents, but eventually in almost everyone, the cancer finds a way around these agents, and that's where some of the newer drugs that we're going to talk about come into play. But I do want to emphasize that the hormonal therapy agents that we have remain the most effective initial treatment. So folks get real excited about new drugs and sometimes think that they might do better getting the newest drugs as soon as possible, but in reality, conventional hormonal therapy can control the cancer often for many years, and we should not skip over these proven treatments to move on to things that might have more side effects and might in fact be less effective when compared head-to-head. So hormonal therapy remains a critical component of treatment for prostate cancer. In addition to the hormonal agents, there are a number of experimental and investigational agents, as well as chemotherapy, immunologic therapy, and injectable radiation therapy, and a number of agents in clinical trials that we hope to touch on in the rest of the talk. Before we move on to these other agents, though, a word about side effects of hormonal therapy. Those men who've been on this treatment are very familiar with this. In some ways, hormonal therapy can be similar to the female menopause in that there's hot flashes, some weight gain, some mood changes, but also loss of libido, erectile dysfunction, a modest increase in the risk of cardiovascular complications, risk of osteoporosis, sometimes breast pain and breast enlargement, and other side effects. And so a critical issue with hormonal therapy is being familiar with the side effects and working with one's physician to minimize or counteract those side effects. Radiation is also useful in advanced disease. We most often think about radiation as a treatment for the primary tumors in the prostate, where it is used to try to cure the cancer. But there are two ways in which radiation can be useful for advanced disease. One is when the disease is locally advanced and we still have a curative intent, although the risk of failure is high, and in that setting, radiation to the prostate is combined with hormonal therapy. And the other is to treat painful metastases or areas at risk for complications. So folks who end up with a lesion from cancer in the spinal cord or in the bones that's painful can significantly benefit from external beam radiation therapy. Typically, when used for pain relief, radiation is given either as a single dose or as a series of doses over about a 10-day course of treatment, which typically takes 2 weeks because radiation oncologists don't work on weekends. I'm just kidding, they do sometimes, but not most of the time. And there is a new form of radiation called Zytiga that delivers radioactive particles to the bone through an intravenous injection and was recently shown to extend survival and also delay the development of pain, broken bones, and other skeletal complications that can occur with very advanced prostate cancer. Immunologic therapy is an exciting new area in prostate cancer. Who would have thought a few years ago that we would be talking about the immune system as a serious tool to fight prostate cancer? We now have one approved immunologic therapy called Provenge or Sipuleucel-T, which is a personalized immunologic therapy where one's own immune cells are processed to essentially teach them to recognize prostate cancer cells as worthy of attack, and then are re-injected back into the patient following this processing. There are a number of other immunologic therapies that are in clinical trials, and I think you're likely to see the immune system as a more and more important strategy for combating prostate cancer in the future. There are a number of these strategies in immunotherapy. One that I thought we would mention because it's accruing patients right now is a vaccine product called Prostvac. This I think is an exciting study that's open at many centers around the country, and for patients who are inclined to consider clinical trials and are interested in immunotherapy, Prostvac is an excellent option to consider. Chemotherapy has a bad name. You know, nobody wants to hear about chemotherapy. But in point of fact, it is an essential component of treatment for prostate cancer. There are several agents that have been shown to be of benefit, including reducing pain, actually improving quality of life, and extending survival. Docetaxel or Taxotere was the first agent to improve survival, and Geftana or cabazitaxel is the newest agent that's been shown to be useful when docetaxel is no longer effective. The advantage of chemotherapy is that it kills prostate cancer in very different ways than either hormonal therapy or immunologic therapy, so it can work when other types of treatments are no longer effective. Bone health is an important component of management of advanced prostate cancer, and I'd like to mention a couple of aspects of that. One, which isn't highlighted in this slide, is the fact that all men who are on hormonal therapy are at risk of osteoporosis or bone loss and should have their bone density monitored and should have calcium and vitamin D supplements and potentially additional interventions to keep their bones strong. But in addition to that, once the cancer spreads to the bones, there is a risk of direct damage from the cancer to the bones. And that can cause bone pain, it can cause fractures, it can cause, in its worst incarnation, lesions in the spinal cord that can lead to paralysis if they press on the spinal cord. And there are a number of treatments that are designed specifically to address the bone complications of cancer. Xgeva and Zometa are treatments that don't target the cancer directly, but target the bone environment and reduce the damage the cancer can do to the bones. These agents have not been shown to extend survival, but they have been shown to delay the development of all of those bone problems that we talked about. Cabozantinib is an investigational agent that may do the same. We're going to learn more about that in the coming years. And Xofigo, I've already mentioned under radiation, is the injectable radioactive molecule that homes in on the bones and is able to kill cancer in the bones and therefore reduce the damage the cancer does to the bone environment. Now, we wouldn't be where we are today without clinical trials, and there are many exciting new treatment options available in clinical trials around the country. That's how progress happens, and we think clinical trials is something that all people living with cancer should be aware of, and it doesn't mean that a clinical trial is always an option for everyone, but everyone should at least know about it and have an opportunity to think about whether a clinical trial is the right choice for their treatment. Clinical trials occasionally can offer new avenues for hope in addition to standard treatments, and often clinical trials do not preclude the use of standard treatments, so they may be simply an additional avenue for treatment that otherwise would not be available. When successful, they can lead to extension of life, better quality of life, and of course, when successful, can also advance the field and create new treatments for everyone that didn't exist before. Clinical trials can also sometimes not turn out as expected, and not every drug ends up being a winner. And for that reason, clinical trials are very closely monitored, so that if a particular treatment doesn't appear to be turning out to be as useful as possible, clinical trials can be stopped early so that as few patients as possible are exposed to treatments that are not as effective as we need them to be. There are many, many clinical trials open across the country, and there's an excellent search engine at clinicaltrials.gov and also at cancer.gov, which is the National Cancer Institute's website, and one can search for them by geography, at a local institution, by type of agent, and so forth. So I'd encourage everyone who's interested to take a look at those websites. A number of important trials that we wanted to highlight are listed on this slide here, and they're included here because they are large-scale trials available to many people across the country. And a sampling of them, as you can see, include ARN-509, which is a hormonal agent, Custerson, which is an antisense oligonucleotide, and if you can pronounce that, you get a gold star. It is a very interesting drug that shuts down a gene that drives cancer's resistance to treatment. So the hope here is that this agent will render other treatments much more effective. Cabozantinib, we've already mentioned, is an oral bone-targeted drug. Prosvac, a vaccine trial. TOC-001 is another hormonal agent. So a variety of different approaches being tested in large-scale trials. Now we wanted to comment a little bit about managing side effects and living with prostate cancer. And this really can happen at any stage of the disease with any treatments. So we're not going to be able to talk about every single side effect and what to do about them. But the common theme is that for many side effects, there are ways to reduce them and manage them with your physician. And guys, tend to be stoic, tend not to want to complain, and we would really encourage folks to report the side effects they experience, because for some things there are things that can be done. For other things there may not be anything that can be done, but at least you will have the assurance that you've explored the possibility that there's some help available. Sometimes that help may involve reducing the dose of the drug you're on. Sometimes there may be a medication or acupuncture or an exercise that you can do to help with those particular side effects. Certainly with pain, the standard today is no pain, and we feel very strongly that any cancer patient with pain should be getting help so they can live without pain. Incontinence is a common complication of local therapy for prostate cancer, and there are exercises that can be done to improve that. If those aren't successful, there are a number of appliances and even surgical treatments that can help with incontinence. And today, few men have to put up with severe incontinence if they get the help that they need. Intimacy and sexual dysfunction is an important topic, and one could give an hour-long lecture just on that. But I'd just like to comment briefly about that. I think when it comes to one's intimate life, it's a difficult topic. There are mechanical issues like erectile function. There are physiological issues like libido loss due to hormonal changes. And then there are huge emotional issues that have to do with partners being worried about their husbands, men being worried about their sexual performance. And so there's lots and lots of difficulties. The mechanical things sometimes can be helped with medications, with surgical interventions. The libido issues are difficult to deal with because the hormonal changes that happen are an essential part of the treatment. But much can be done through a more creative and open approach to intimacy with living with cancer. I've attended some really wonderful lectures where part of what's rarely talked about is renegotiating intimacy and finding ways to maintain an intimate connection with one's partner, even when mechanically it can't be the same as it was before, and not just looking at things as all or nothing, where if we can't do what we once did, then we're just not going to have an intimate existence. So there's much literature out there, there are books, and there's a lot of help, and I think this is one of those topics that often doesn't get brought up and doesn't get discussed. Very important for relationships and for overall happiness, and I'd encourage folks to take an open approach to discussing these issues and seeking solutions that are appropriate for their particular circumstances. Boy, a pretty busy slide here. I think I will leave this slide as a reference for the audience for the future. Suffice it to say, each one of the treatments that we use has a particular spectrum of side effects, and it's worth being aware of those side effects heading into treatment. It's also important to know that Not everyone gets every side effect, so these lists aren't intended to predict the future with 100% accuracy for a man who's about to undergo one of these therapies. And for many of the side effects, they occur in a minority of patients. So everyone's experience with their toxicity of treatment is a little bit different. Finally, we wanted to touch on nutrition. I'll confess I'm not an expert in nutrition, so this is an area that often comes up, and I often get some help from our nutritionist on that. But I can comment in general about this. Obviously, it's something that comes up a lot. First of all, for men who already have prostate cancer, there have not been very many large-scale, well-conducted studies of dietary change that have been shown to have a big impact on cancer outcomes. Those studies are very hard to do, and so they don't get done very often. So most of what we know about prostate cancer and diet comes from studies that look at the risk of developing cancer rather than outcomes once cancer is diagnosed. And from those studies, what we've generally learned is that diets that are rich in fruits and vegetables, light on animal fats and red meat, diets that resemble the Mediterranean diet, for example, can be associated with a lower risk of prostate cancer and may also help once the prostate cancer diagnosis is already made. Furthermore, it's probably safe to say that what's heart healthy is prostate healthy, and that's something that my friend Mark Moyad from the University of Michigan has pounded into my head every time I go to one of his talks. And there are two reasons for that. One is that the heart healthy diet is a generally healthy diet with lots of fruits and vegetables. The other is that the majority of men diagnosed with prostate cancer die of heart disease. And so, and I'll repeat that, the majority of men diagnosed with prostate cancer die of heart disease and not of prostate cancer. So it would be imprudent for us to look for diets that only help prostate cancer and aren't good for the heart. And in point of fact, if you had a diet that was pretty good for prostate cancer but was just a little harmful for the heart, on balance, that probably would be a bad deal in terms of survival. So a good rule of thumb is whatever your cardiologist or general internist recommends for your heart health is probably a good idea for prostate cancer as well. So to be more detailed, we generally recommend significantly increasing the intake of fruits and vegetables, particularly colorful fruits and vegetables, cruciferous vegetables such as cabbage, broccoli, and cauliflower may be particularly useful. Red grapes and products from red grapes in some studies have also been shown to be particularly promising. Calcium, one has to have a balance about. It's important to have enough calcium for bone health, but not too much calcium. Pomegranate juice has shown some promise. Tomatoes have shown some promise. Green tea has shown some promise. None of these things are viewed as definitive and absolute, but these are the general guidelines that we provide to our patients based on what we know today. Finally, today's talk is not going to cover every topic, and even if it did, the state of knowledge of the field is going to be different next week and next month and next year. So like many things in life, living with prostate cancer needs to be a continuous learning process, and staying informed and involved is key. To do that, the single most important thing I think one can do is maintain excellent communication with one's physician and their office staff and nurses. There's more to it than that, but that's the critical thing. So this slide contains some sample questions that people can take with them so that they can get some clarity as to where they stand. And these are basic common sense questions, things like what exactly are the results of their tests and what does that mean? What are the results of my PSA, my testosterone? How are you deciding on the treatments that you're recommending to me? Why what treatments are you recommending and why? What are the alternative options, and how should we make that choice? For whatever treatment we're considering, it's good to ask, what are the goals? What are the expected positive outcomes? What are the chances of side effects? What are the chances of success? And then finally, how long will it take before we know if we're on the right track or if we need to change treatments? I already mentioned side effects. In addition to that, are there any lifestyle changes or restrictions on other medications, exercise? Do supplements help or hinder the treatments? Some treatments, for example, chemotherapy, can be interfered with by antioxidants. So there are some things that one needs to know about specific supplements and treatments. How can my loved ones help? Oftentimes, family members and friends are eager to help, and sometimes they help by offering a ton of advice, which can be good, but not always. So thinking about how the people that want to help can help you is really important. And my personal views on that is there's lots of things people can do. They can accompany the patient to a doctor's appointment. They can give them a ride. They can take him out for dinner and not talk about cancer. They can help at home. They don't have to necessarily scour the internet and provide printouts of everything that's ever happened. Not that that's not a good idea, but people want to help, and whatever it is that you need, don't hesitate to let people know what would be helpful to you, because those that care about you really want to help and often are at a loss as to what to do. Clinical trials is something we always encourage folks to ask about, and sometimes there's a role for a second opinion, and a good physician will never object to that and would encourage that. So if you're at a critical juncture in the management of your cancer, there's a big time decision to be made about treatment. It's not a bad thing to say, is this a good time to get a second opinion, and where would I go for that? Okay. So at this point, I'm going to turn the mic over to Evan for some closing remarks, and then we'll do our best to look for questions. So go ahead and send us questions through the electronic typing system that's in front of you.
Thank you, Dr. Bear. A lot of information there over the last 35 minutes or so. We've got a couple of questions that have come in, and Adam, do you want to have a look at that one? And
let's see. One was, can you we'll see. There's a question, what are the options for patients with oligometastatic prostate cancer? So for those that don't know what that means, oligometastatic means there are few metastases and not many. In general, we approach those patients in the same way that we would approach patients with more advanced disease, although we recognize that the prognosis is much better. So when we look, for example, at how long hormonal therapy works on average, and it can work for 10 or 20 years for some patients, but on average, hormonal therapy works for about 2 years for patients with very extensive metastatic disease, and around 4 years for patients with limited or oligometastatic disease. So we know that the prognosis is better. We need to plan for the longer term, but the treatments per se are not different, regardless of how extensive the disease is.
Great, thank you, Mr. I think it was Mr. Miller who submitted that. Also, we've got you mentioned clinical trials in there, and I know that's an area that is of great interest to you. You mentioned those couple of great websites. If someone goes there, how would they go to the next step? Do they just pick up the phone and call, or do they go through their doctor? What's the kind of the typical way that they would, if they saw something that was really appealing to them, how would they really get involved?
Right. So there are different ways to learn more and get involved with clinical trials. If your physician is at an academic medical center or in a private practice that is very involved in research, they may be your best first point of contact, and they may have clinical trials available to you at their practice site and eager to discuss those options with you. If you're left, so to speak, to your own devices a little bit on that front, the thing to do would be to spend a little bit of time with the search engines to learn how to search for clinical trials that fit your particular situation. And I wrote a whole book chapter on how to do that. It's a little hard to summarize that on the microphone, but if you spend a little bit of time on the cancer.gov website and look at all the various categories, one can pick type of cancer, type of treatment, location in the country, type of drug, and so forth, and find clinical trials that sound interesting to you. At that point, one typically would want to print out the information and discuss it with one's doctor, and it may be a good time for a second opinion at an academic or research-oriented medical center.
Question from Mr. Stevens, or did we?
Yeah, I think we have several questions here, so let me take them all.
Yeah, go for it.
Okay, so Mr. Stevens' question: after RP, if PSA starts to rise, when should treatment begin? What PSA level? So a detectable PSA after prostatectomy indicates persistence of cancer almost always. Certainly a rising PSA does indicate that. The first question that we ask ourselves is whether radiation is useful in that setting, because radiation can occasionally, more than occasionally, eliminate the disease for the long term. And if radiation is indicated, typically, ideally, it would be given below a PSA of 0.5. The higher the PSA, the less likely is radiation to achieve its goals. If radiation has already been given, or if it's not thought to be likely to be useful, then it's a much more difficult question, because oftentimes a slowly rising PSA probably should just be observed because the risk of problems is relatively low. On average, men with a rising PSA after prostatectomy live about 13 years, and that includes all the high-risk individuals. Those that are at low risk may live for 20 or 30 years and may not need treatment for a decade. So we pay a lot of attention to how rapidly the PSA is rising to make that decision. The next question from Mr. Driscoll. So is it not necessarily true that if a man develops prostate cancer, he automatically loses libido? That's right. Loss of libido is almost always related to hormonal therapy. So surgery or radiation alone often do not interrupt libido, or may diminish it a little bit, but not completely. And the really big decline in libido happens when testosterone is taken away on hormonal therapy. Now, for many men, hormonal therapy can be given intermittently or for a limited period of time, and the libido can come back. Now, one of the mysteries of life is that about 10 to 15% of patients on hormonal therapy still have a libido, even though their testosterone is low. And frankly, if I understood exactly why, I'd be a very wealthy man, and we would be inventing some sort of a pro-libido drug that would make everyone really happy. We don't really understand why that is, but it does happen. Is there a link to share with support groups? Share this with support groups. You mean for this particular seminar? Will there be a link on the Zero website?
There will. Since we are recording this, this will, actually when we get to the next slide, through our website, zerocancer.org, certainly this webinar and others in the future, you'll have great opportunities to link in and share this this particular webinar, as I said, and others. You can download different resources that we have available. It'll expose you to the different things that you might want to do to take part, take action. So absolutely, you can or will be able to, not today, but in the very, very near future as we get this all processed, but certainly within the next week, have access to this this webinar to share around on Facebook and other support groups and whatnot.
There's a question here, will a copy of the slides be made available, I assume, for someone who might want to give a talk, or is it just going to be online to view?
They will be online to view. If you'd like additional information, if you go one more slide, we'll just hit that keypad there. You can certainly reach out to Ivy, who's our Director of Patient Education, or myself. Our information is on the screen there. If you're looking for a copy of those slides and you can't find them online or unable to download them, please reach out to us and we can certainly answer any questions or get you any materials that you may need. So certainly feel free with comments and questions to reach out to Ivy or myself regarding this webinar.
So I'm getting more questions here from Michael. When PSA is rising and in triple digits, what are the odds of success with Zytiga? So I assume we're talking about a situation where the PSA is rising and standard hormonal therapy has already been used, because that's where Zytiga has been studied. Typically, studies have shown that about 2/3 of patients respond very well to Zytiga, and maybe a somewhat higher percentage when you consider just disease stabilization or a modest response. So the odds of initial response are quite good. The majority of patients benefit from Zytiga. The duration of benefit varies a great deal from person to person. In folks who have not been through chemotherapy, it's about a year on average, but that average has very large extremes, and I've seen patients whose cancer is still controlled by Zytiga after 3 or 4 years of therapy, and we don't know how long it's going to be.
One other thing maybe you could just address, we've got a few minutes left. You mentioned earlier that obviously getting a second opinion is highly advisable, and most doctors, as you mentioned, would be generally open to that. But what if the patient's having a difficult time, or the doctor's not being very responsive? Any tricks or anything, any advice that you can give that might make it a little bit easier for a patient or a potential person to kind of get that second opinion?
Yeah. Well, so first of all, I think if a doctor is being difficult about a second opinion, you should get a new doctor. I mean, that's not to be too direct, but that's just a standard appropriate thing to do. And I really don't know anyone in my area who would discourage second opinions. But if one is left to their own devices to try to figure that out, in general, large academic centers, medical schools, have physicians that subspecialize in individual cancers, which is one of the things that makes those centers unique. So probably one's best bet is to look at on the website of the nearest large academic medical center and look who's specializing in prostate cancer at that center. Ideally, if you're going to go to the trouble of getting a second opinion, you'd want to see someone who really has a deep level of expertise in that disease, and that's really somebody who focuses on prostate cancer full-time.
Is there a new question there?
Post-tax here and hormone resistant, going on Zytiga and sounds encouraging. Oh, so I guess that's just a comment. So, yeah, I think Zytiga and Xtandi are really outstanding new medications that are have really changed the spectrum of the disease and changed the face of our clinic. We're using a heck of a lot less chemotherapy right now because so many patients are on Zytiga and doing well, and Xtandi and doing well. We think eventually we'll need to use chemotherapy for those patients as well, but if you look right now, many of our patients are doing well on these drugs. So it's been a really exciting time, and I wish you well, Michael.
Great. Well, I think that's it for the question. Oh, there was one I think just came in.
Is Zytiga approved for use with Xofigo? The short answer is no. Xofigo was studied with conventional hormonal therapy and not with other agents in combination, and Zytiga was studied without Xofigo. In principle, the two drugs should be able to coexist. There's no biologic or clinical reasons why they couldn't be mixed together. In our practice, we tend to sequence them so that we can better assess how each drug is doing and what the side effects and benefits are of each drug. But they could be combined, at least hypothetically.
Great. Eddie, you talked a little bit about the support network, which is obviously incredibly important. There are groups out there, us two being one of them. Are there any other things that you can lead to from, obviously, family support is incredibly important. But a lot of men, no offense to any of the doctors, but love to talk to somebody that's been through the experience. Mm-hmm. Is there anything you can shed? I mean, obviously talking to your doctor is a huge asset, and your family, close family support. Is there anything else that you can lend to from the support network side as someone's been recently diagnosed or going through treatments that comes to the top of your head?
Well, I think there are a number of ways to get that peer-to-peer experience. I think you've already mentioned Us Two. Us Two is one of the organizations that unifies many support groups around the country. Not all. I mean, there are support groups that are part of Us Two and some that aren't. But I think most folks that I've interacted with, nearly all that have gone to a support group, have really found it to be enormously helpful. There are also man-to-man programs where there's one-on-one sort of peer support. Some people aren't comfortable coming into a big room full of guys and disclosing what's on their mind. The American Cancer Society has supported that. Medical practices, of course, have, in addition to support groups, which are peer-to-peer, have social workers and other folks that like that, who one can turn to, particularly when it comes to relationship advice or intimacy advice. I think social workers can be enormously helpful.
Great.
It says here, man-to-man has been canceled by ACS as of August.
Okay, don't go there.
Yeah, so we'll, I think ours is still going as a renegade route, but I'll follow up on that. Looks like I'm a little out of date on that.
Great. Well, in light of any other questions, I'd like to bring this to a close and thank Dr. Tom Baer for his time and all of you out there who've logged in and taken the time to listen and respond. It's greatly appreciated. Again, if you'd like to follow up on this, Ivy or myself are welcome to, please feel free to email us or give us a call with comments or questions or requests. And of course, once again, to our sponsors, if we could just give them a big thank you to Oncogenics, Teva, Oncology, Bayer, Exelixis, Millennium, Astellas, and Medivation. Without them, these sorts of things wouldn't be able to take place. Just another quick reminder, there's a survey as you will exit, so please take a moment and fill that out. We greatly appreciate it. And we look forward to seeing you soon. And please check back to zerocancer.org, as this webinar will be up online and be able to be emailed around or revisited at your convenience within the week or so. So thank you, everyone, for taking part. We look forward to hosting another one of these in the near future. Thanks, Dr. Baer.
Yeah, thank you very much.